slides quickly. They emphasize on certain aspects regarding inflammatory bowel disease. So the objective of our talk today are to differentiate inflammatory bowel diseases from other differential diagnoses, to identify the differences between Crohn's and ulcerative colitis, and to know how to diagnose IBD, and at least just know a little bit about initial management of them. Now, this is the content, so these are the contents that we're going to cover today. We'll try our best to cover them today. I know we started like a little bit late, but we'll try our best to go over them. And you're more than welcome at the end of the talk. If we don't have time, you can approach me through email, the hospital email. I can share with you later on, or by contacting me if you like. So when we talk about inflammatory bowel disease, we're talking about a group of chronic idiopathic intestinal diseases characterized by inflammation of the bowel, the large or small intestine. Now, remember, the definition usually helps you to try to identify the diseases. So like you can see clearly that we're talking about chronic diseases, non-acute diseases. So the patient should have at least 4 weeks of ongoing symptoms at least. And they are idiopathic. So if there is an explanation for the inflammation like vasculitis or infection or whatever, then this is not idiopathic. So this is not characterized as IBD. So talking about idiopathic diseases, and they should be chronic. Most common types that we talk about are ulcerative colitis and Crohn's disease. And there are other subtypes, but they are not common and they are beyond the scope of this talk, so we'll not, talk about them in details. The others are microscopic colitis, and as the name indicates, it means that when we go with the scope, we don't see any inflammation. Rather, when we take a biopsy, you see it in microscopy. And they have a specific treatment. Microscopic colitis is being treated differently. Indeterminate colitis is a colitis that you cannot tell whether this is ulcerative colitis or Crohn's colitis. So there are at least 10% of patients who upfront comes to you and you go in and you investigate, and they'll end up with saying, is this patient colitis secondary to Crohn's or ulcerative? And so we call it IBDU, or inflammatory bowel disease, unclassified. And when you take the colon out by surgery, even the pathologist cannot tell whether this is really Crohn's or ulcerative colitis, so we call it indeterminate colitis. So indeterminate colitis is the terminology that we use after pathology specimen of the colon. But if it is before and you cannot tell before taking the colon out, we call it inflammatory bowel disease unclassified. Again, this is a little bit advanced, so we'll not maybe go into details about it today. At any time, guys, if you hear an interruption in voice or slides, please let me know. So we're talking today about inflammatory bowel diseases, not IBS, not irritable bowel syndrome. So we're not talking today about irritable bowel syndrome. I believe you will have a chance to hear about it from our colleagues in family medicine, or maybe by someone, another colleague from gastroenterology. But definitely, we're not talking about IBS today. I mean, it's confused a little bit by other people. So they think IBD is IBS, so قولون عصبي, قولون تهيجي. No, we're not talking about this. Talking about أمراض الأمعاء الالتهابية or inflammatory bowel diseases, مرض Crohn's, والقولون التقرحي, or ulcerative colitis and Crohn's disease. So when we talk about IBS, this is just a hint for you. So we use room for criteria for irritable bowel syndrome. You can clearly actually among those that to know that IBS is diagnosed by exclusion, not like IBD. So you need to rule out malignancy. You need to rule out IBD before you say that the patient has irritable bowel syndrome. Irritable bowel syndrome is far more common than IBD. So قولون عصبي, we talk about 10 to 15, up to 20% of general population, 1 in 5, 1 in 10 of the general population will have at one time in their life and symptoms suggestive of irritable bowel syndrome, which has certain subtypes. But IBD, you're talking about prevalence in the highest countries of 1 in 1,000 or 3 in 1,000, or in some areas even reaching down to 1 in 100. So it is less common. So IBD is less common than IBS, and it has more, complications and need for immunosuppressant medications and surgeries and life quality impact more than IBS do. So if you are not a gastroenterologist, you're not even an internist, and you end up with doing a surgical specialty or gynecology specialty or family medicine, so it would be nice to have a referring tool, a tool that you can use to identify early patients with inflammatory bowel disease, so you can refer them to an internist, to a gastroenterologist later on. So this tool comes in handy, called IBD screening referral criteria, that we can apply it, and it has a scoring system. And just prefer to show it to you, especially for those who may be not planning to join internal medicine or gastroenterology among you guys. So you can use this tool to help you identifying if there is really a hint of ongoing inflammation. So you can see that presence of vaginal disease, nocturnal symptoms is one of the things that we put a lot of weight on. There is family history, if there's weight loss, and if there are specific abdominal pain characteristics, like if there's cramps after vegetables, and definitely the presence of fever gives a lot of weight to patients. So accordingly, if the patient has a score more than 6, then it would be wise to refer him to a gastroenterologist to either confirm or rule out presence of inflammatory bowel disease. So eventually the patient might have just no IBD yet. I mean, at least you referred him early, so it can be identified or recognized before complications starts. Now, this is, I would say, a bit time story, but I mean, it would be wise and to know where come the description of ulcerative colitis and Crohn's disease comes from. So I tend to say ulcerative colitis is the older brother of both diseases. It was described by Sir Samuel Wilkes, a British physician, in 1859. And he's the first one who used the terminology ulcerative colitis, while Crohn's disease, you know, is less than 100 years old, was named after an American gastroenterologist called Beryl Crohn's. He and his colleagues, Dr. Jensberg and Dr. Oppenheimer, in 1932, they published their paper in the JAMA. You know, at that time, they used to organize the names of the authors alphabetically, so using the surname or the family name of the author. So Crohn's came first. I mean, rather, Jensberg is the surgeon who initiated the idea of collecting what they called idiopathic, non-tuberculous granulomatous terminal or regional ileitis. So this is the paper title. It was idiopathic, non-tuberculous terminal granulomatous regional ileitis. So Jensberg, with his colleague, the Dr. Oppenheimer, the surgeons, came to Dr. Crohn's and like asked him if he has some cases similar to what they have from their surgical specimen, where they have granulomatous inflammation affecting the terminal ileum, the last part of the small bowel, but they were negative for TB at that time was the predominant explanation for granulomatous inflammation. So they started collecting those patients, and Dr. Crohn's as well supported with his number of patients that he has, and they published their first case series or cohort of patients with such disease. So ideally, you should have called the disease Jensberg disease, but I mean, as I told you, because of the alphabetic, order, Crohn's his name was first, so we started calling the disease as Crohn's disease. Now, after this bit time story, I mean, this is to emphasize on the epidemiological facts of inflammatory bowel disease. You can see that IBD prevalence in the highest areas. So we talk about different prevalence from different countries. So we, maybe in the Middle East and North Africa, have less that prevalent disease than North America and Europe. So the highest is 3,000. Actually, this is a little bit maybe old. This is in 2017. Now there are some recent reports from UK that the disease in 2025 will reach to 1%. So that means we are getting even higher, or an increase in the number of prevalence of the diseases. So the incidence, on the other hand, and you know the difference between prevalence and incidence. So prevalence is the whole pool, the number of patients diagnosed with the disease at one given time. Incidence is the newly diagnosed cases per year. So the incidence is stable or decreasing in North America and Europe, while it has been rising in United States countries. So we are, for example, Saudi Arabia, diagnosing IBD this year more than what we diagnosed the year before, and more than what we diagnosed 10 years before. So the incidence in our countries are rising, and this is definitely affecting the whole pool of prevalence. So at one given time, we'll have more diseases. This is why we need to pay attention to those diseases, and this is the beauty of epidemiological data. Some people might wonder, why do we need to remember numbers? It helps you to address the whole problem on national level, and for you as a physician, it helps you when a patient comes to you complaining. You know exactly how common is that disease, so you say, yeah, we tend to say common things are common, so that disease is so rare, I don't think you have it. That disease is more common, I think maybe we need to rule it out. So data or numbers helps you usually to diagnose as well. I would tend to say colder climate and urban living. If you're living in areas, in the cities and big towns, you are more prone to develop autoimmune diseases in general, and IBDs among those. But if you are born, for example, in a farm or in a small village or small town, or being raised in the rural areas, this decreases the likelihood of developing autoimmune diseases, and this supports a little bit some of the rule of vitamin D deficiency. Some epidemiologists thought that people living in colder climate in the northern hemisphere or the northern even areas of any country, you have less vitamin D. So this could contribute in a way or another to the pathogenesis of autoimmune diseases, and as well the health hygiene or the hygiene theory. So we believe people who are born in rural areas maybe are exposed to different bugs and dust, so it makes them less risky to develop, autoimmune diseases. With hygiene theory, if you're interested, you can just, search about hygiene theory, what it means. Like in bronchial asthma, that means if you are living in a very sterile condition, you are exposed, the immune system will be, triggered by self-antigens, while if it's busy and caught by foreign antigens, then this will minimize the risk of developing autoimmune diseases. So this is just, a graph reflecting what we talked about. So on the left side, the red bars, you can see the incidence, the prevalence, and the great acceleration of prevalence in the Western countries. And while in the blue bars on the right side, it shows in the newly industrialized countries, China and Asia and Southeast Asia, and as well in Middle East and North Africa. So our incidence is rising. At one time, actually might reach to the same incidence prevalence as in Western countries. And I believe there is definitely a thing that we maybe inherited from the Western world, like, Western lifestyle, fast food, restaurant chains. All of these may be contributing to what we are seeing now by the rise of the autoimmune diseases. So this is just showing you the Crohn's disease, this map, and you can see that Saudi Arabia is among the light blue. So we are sitting in range of 0.8 to 2 per, this is like per 100,000 patient, per 100,000 population. So, well, among so far the, low prevalent countries. This is an age-specific incidence. It's an old one, yet still applicable. And on the left side, you can see the UC, and the right side, Crohn's disease. And there's what we call it an M-shaped, two-peaked graph or curve. You can see that most of the patients we diagnose with IBD is in their late childhood, teenage, and early 20s. But this doesn't mean that we can diagnose patients in their 30s or 40s yet. I mean, we diagnose less patients in that age. And then there is another peak in the 50s to 60s. So again, as I told you, we can diagnose IBD throughout the age, yet we have those peaks. So if you asked about the age-specific incidence, you can remember the M-shaped. So there are two peaks, early 20s and teenagers and late 50s, 60s. So pathogenesis, pathophysiology of the disease is a long subject to talk about. It's not the idea to cover it here. Yet just to give you a hint about it and how to, look at the disease overall. We tend to say, in the past, we tend to say this is an autoimmune disease, that's it, just forget about other things. Now we start to understand a little bit, yet we don't have a full theory that explains the whole disease. So we still say it's poorly understood, yet we start to have some hints about interaction between different factors. So we know that genetics plays a role, yet it's not the only player in the game. And definitely exposure to certain environmental triggers, smoking, for example, or the reduction in breastfeeding, or exposure to antibiotics early in childhood could play a role as well. And definitely interaction with the gut microbiome. All of these three factors in the top row will lead to a dysregulated immune system. So it's not an overimmunity, it's not an underimmunity, it's a dysregulated immune system that will trigger the leukocytes or the lymphocytes or the activated abnormal lymphocytes to target certain tissue, and in this case of inflammatory bowel disease is the mucosa or the wall of the gut, like in Crohn's disease. So this will lead eventually to inflammatory bowel disease. If we have a quick look deeper, then this is just interstitium, and you can see the brush border of the gut in the upper part of the picture. You can see here that there is an antigen outside, whether this is the bacteria, the gut microbiota, or a certain antigen that comes into the antigen-presenting cell in the middle. I hope you can see that, my arrow. And then this will, in its own, activate a T helper 1. So we tend to say in Crohn's disease, it's a typical T helper 1 reaction, while in UC, it's an atypical T helper 2 reaction. But regardless, that antigen, if we manage to recognize it, would be, nice, but we assume that there are different antigens that could, initiate or trigger the inflammation. That will eventually lead to activation of one of the specific immune cells, like the T helper 1 or T helper 2. And by different cytokines, and maybe it would be nice to recall your pathology and immunology basic understanding, the definition of cytokines and interleukins. So by releasing the cytokines, this will lead to further cascade of inflammation eventually lead to the inflammation and the injury to the bowel. We tend to say there are certain pro-inflammatory cytokines, anti-inflammatory cytokines, and for example, interleukin-10, tumor growth factor, beta are called anti-inflammatory cytokines. So if you have an imbalance between both, this might, we think, lead to further cascading inflammation of the gut. Try to go over this quickly as well. So genetics and IBD, why do we think genetics plays a role? This comes from the fact, the rationale behind thinking, why do we think genetics plays a role, is the fact the presence of family history plays a role. We've seen patients with family clusters, 2, 3 family members in the same disease, or with IBD or autoimmune diseases. And as well, monozygotic twin studies has shown as well concordance more in Crohn's disease. So if you ask which disease has a higher genetic or familial background or tendency, we tend to say Crohn's disease based on those monozygotic twin studies has more concordance. And what we mean by concordance is that if twins from the same ovum, we call them monozygotic, one of them has been diagnosed with Crohn's disease, the likelihood that the other one will be diagnosed with the same disease is 58% in Crohn's disease, while it is less in ulcerative colitis, giving Crohn's disease more genetic background. And as well, the third reason why do we think genetics plays a role is the racial and ethnic patterns. And I believe most of you know that there are certain ethnic group, mainly Ashkenazi Jews, so not all Jews, Ashkenazi Jews has higher tendency to develop Crohn's disease specifically, and a difficulty to get Crohn's disease. The genome-wide association studies, and lately as well the whole exome sequencing studies, has found even up to 300 IBD association loci, and they are not just only etiology or loci. If you have them, then you will have the disease. It's kind of an association, whether you have a poor outcome or will have resistance to certain medications. So, overall, the genetic studies has shown some possible association. This brings the importance of genetics, but it is not the sole, it's not the only player in the game, as we mentioned, because we have a lot of patients who have their family members who are doing fine. So, and you cannot predict that, like the monogenomic diseases like sickle cell, you cannot predict that in the next generation. So just one thing to remember if we move aside, guys, for sake of exams. So remember that NOD2-COL15 is one of among the earliest genetic mutations that has been described in patients with Crohn's disease. It's been associated in Caucasians, not in Asians, and in Caucasians to develop a severe difficulty to get Crohn's disease. So just remember at least one of those, difficult really to remember all of them. Now, what is the importance of human microbiome? In the past, we tend to call them gut flora, but flora is under the kingdom of plants. So microbiome is not, so call them microbiome now. We're not calling them flora. Just one thing to bring to your attention, the importance of the interaction of what we have of bacteria, what we tend to say beneficial bacteria in the lumen, is that the number of the gut microbiome or the bacteria you have, or an average human person has in his gut, is actually 10 times higher the number of the cells in the body. So something huge in your gut definitely has something to do and interact. And if you just quickly search through PubMed about association between gut microbiome and other different diseases like depression, multiple sclerosis, cardiovascular disease, you'll see some association. So definitely being in the gut, they're interacting. As we mentioned, that there's this theory that maybe an antigen of one of the beneficial bacteria, one of the gut microbiome, interact in a way with the human immunity and triggers the cascade of inflammation. Now, this is just taken from one of your books, Davis, I guess. It's just to show you the differences. If there was maybe a face-to-face lecture, I usually ask you guys about what are the differences that you expect. Yet, for sake of time, try to go over this quickly. Just remember here, the gender difference is not major, and as well the age group difference is not major among both diseases. When you come to ethnic group, as we mentioned, Ashkenazi Jews has more tendency for Crohn's. Now, genetic factors, as we mentioned, COL15, NOD2 before association with Crohn's disease, and HLA, DR103 with ulcerative colitis. Now, we talk about risk factors. This is as well an important difference that you might be asking about in exams regarding smoking. So smokers develop Crohn's, ex-smokers develop ulcerative colitis. Yet, we tend to say, what about those who never smoke? So we said ex-smokers will develop UC. So yeah, we think smoking has some potential protective role in patients with ulcerative colitis. So if you are a smoker, you're less likely to have ulcerative colitis, yet the overall risk of developing inflammatory bowel disease-associated cancer, even in ulcerative colitis, is higher in smokers. So overall, if you have a patient with ulcerative colitis, you ask them to quit smoking. Now, when you talk about anatomy, I mean, I believe you know this. So when we say ulcerative colitis, it's restricted to the colon, as the name indicates. So it's colitis. And it begins usually distally and go proximally. So So it starts at the anorectal margin with variable proximal extension. It either goes to the sigmoid colon, as you remember from anatomy, or to the splenic flexure of the colon, or all the way to the cecum. While Crohn's disease, on the other hand, can affect any part of GI tract. It has perianal disease as well as is common. It's reaching up to 25% of patients. 1 in 4 patients with Crohn's disease will develop at one time perianal disease. And it has a patchy distribution. So it's not continuous inflammation like you see. It has a skip pattern. This is another feature that is predominant in patients with Crohn's disease. Now, extravascular manifestation that we come to later on are common in both. So it doesn't define or help you to differentiate between them. Presentation, usually it's bloody diarrhea because there's colitis. So there's bloody diarrhea or only diarrhea and also colitis. In patient with Crohn's disease, the variable they have depending on the location, right? So in Crohn's disease, usually if you want to be safe, if you're asked about presentation, say it depends on the location of the disease, right? So with the most common presentation is usually right iliac fossa pain, because this is the most common site of involvement, which is the last part of the small bowel called terminal ileum, and the first part of the colon, which is the cecum. So this is the most common site. So if I would ask about the most common presentation, then I might say, yes, right iliac fossa, abdominal pain, diarrhea, and weight loss. But if you ask in general, then you say it depends on the location, because some patient might have just only isolated perianal Crohn's disease. Some patient might have isolated upper GI disease. Some patient might have isolated rectal disease or isolated Crohn's colitis. So it depends, and they will end up, say, having bloody diarrhea similar to ulcerative colitis. So it depends on the presentation. We'll come to that later on. And again, histological differences, and I definitely cannot emphasize the importance of remembering this, guys, for clinical part and as well for your exam purpose, that the histology, in ulcerative colitis is limited to the most inner part layer, which is the mucosa. While in Crohn's disease, it's a transmural inflammation, so it affects the mucosa, the submucosa, the muscularis, and the serosa. And this is why actually a patient with Crohn's disease, they have, fat, wrapping and creeping because the serosa is activated. And this is why they end up with complications more than you see, like stricture and penetration and fistulizing, because it's a transmural inflammation. We'll come to that later on. Other features are the granuloma. So granuloma is seen in Crohn's disease rather than UC. So most of the coming slides actually will just be emphasizing on what we talked about here. So this is, as we mentioned early on, about the difference between ulcerative colitis and Crohn's. Remember, we said ulcerative colitis on the right side here is starting distally, so anorectal area, then it's continuous pattern and goes proximally with different extent. Crohn's disease can affect small or large, can affect the rectum, can affect any part, and it has skip pattern. And this is again to emphasize the fact that I mentioned earlier on in that table differences. Ulcerative colitis, you can see it's affecting the most layer, which is the mucosa. While in Crohn's disease, it's transmural inflammation. You can see this is why it can lead to complication like penetrating disease and more common stricture, fistula, and abscesses because of the transmural nature of the inflammation. Again, this is showing you what we talked earlier about in the gross pathology. If you look, this is in the upper row now, talking about the gross pathology. So it's normal here in the left side, and you go to the middle for Crohn's disease, you can see the thickness of the wall and the fat wrapping and the cobblestone that happens in Crohn's disease. While in ulcerative colitis, you have a thin wall, you have an ulceration, you have a pseudopolyps. You can see both, but are more common in ulcerative colitis. And if you go to the second row in the middle, this is the histological differences, and the lower row is the endoscopic difference. So we can see here in the middle the presence of granuloma and the curve distortion that will happen in both in ulcerative colitis or Crohn's disease. The pseudopolyps are more common in Crohn's disease. It doesn't mean that it doesn't happen in Crohn's. And the cobblestoning is a more feature because of the, we call it linear nature of the ulceration that leaves normal mucosa in between, giving you a cobblestoning appearance. And you can see a normal scope on the left lower quadrant here. Again, this is another table to show you the difference. Actually, I put it just for sake of the surgical option here, guys, because we talked about the other differences early on and the colorectal cancer risk. So we tend to say patient with the UC has a higher risk for colon cancer simply because it affects the organ. And because Crohn's disease mostly affects the last part of small bowel and the cecum, so it doesn't affect the colon. So it makes sense that patient with ulcerative colitis who has colon affected to have a higher risk of colon cancer. And surgical option can reach up to, maybe this is an old as well number, but now we are getting the number less and less. But we tend to say the need for surgery is less in ulcerative colitis while it's higher. Let's say 3 out of 4 patients will eventually need surgery, but we are trying as well our best with using medical treatment to minimize the need for surgery in Crohn's disease. Now, this is what we call the categorization of inflammatory bowel disease. I think we have like 30 minutes to go, try to go over them and move to the diagnostic criteria and management steps. But this is like to show you the categorization of ulcerative colitis and Crohn's disease based on extent. So we have different way of classifying disease, especially for Crohn's disease. We have severity, we have age, we have behavior for Crohn's disease. This is showing you the classification based on extent of the disease. So if the ulcerative colitis, we can have proctitis, which is limited inflammation to rectum, or left-sided colitis, that means proctus sigmoiditis, or extensive colitis, and we'll come to that, what that means. And for Crohn's disease, can affect only upper GI or upper GI plus. The most common part is usually the last part of small bowel, as we mentioned, and early, or the first part of the colon as well. Or could be pure colonic, could be pure anorectal disease. Now, this is just to show you the expected possible scenarios for clinical course. Some patients with Crohn's or ulcerative colitis might have one big flare initially, followed by small flares. Some patients might start with the opposite, then have a progressive disease eventually. Some patients might have chronic continuous symptoms with never going back to normal baseline, and some might have like chronic intermittent symptoms where they go in between attacks to completely normal. I have certain patients, especially with Crohn's disease, who might have one attack and then after just, especially those with mild disease, might go into remission, long-term remission with or without medical treatment, but it's still very difficult to identify those patients who will behave, benign after the initial attack. So usually it's challenging, and this is why people are developing what we call predictors to know exactly which patient will go to more progressive disease, which patient will have a nice, smooth disease course after the first attack. So we can, hit hard or treat aggressively patients with more, poor prognostic factors. And this is why it's important to identify prognostic factors. Can I just maybe to bring you back to bring your attention to focus here more. So can I have someone, I'll read case number 1. I want someone to tell me, what do you think? This is a Crohn's or UC, based on what we talked or based on what we will talk later on. So case number 1 on the left side, 19 years old gentleman who presented to outpatient clinic complaining of non-bloody large volume diarrhea for the last 8 weeks, which was associated with moderate right iliac fossa abdominal pain for the last 6 months and 5 kg weight loss over the last 8 weeks. So guys, what do you think? This is ulcerative colitis or Crohn's? Most likely again. Anyone? Just open the mic and speak.
Crohn's disease.
So most likely it's Crohn's disease. Based on, I will just go quickly over it. So we tend to say large volume diarrhea is more of small bowel source. So this is one. So most likely this is small bowel. Being non-bloody, making ulcerative colitis less likely, yet doesn't rule it out. So this is something chronic. It's been ongoing for more than 4 weeks. So it's been ongoing for 2 months at least. And there, this, as we mentioned earlier on, the right iliac fossa abdominal pain. So making it most likely he has the most common presentation, which is ileocolonic or ileocecal presentation, the presence of weight loss. So let's just compare that with most likely the UC case on the right side. So 26-year-old lady who's coming with bloody diarrhea. Okay, so 3 weeks, but she's been having on and off some symptoms over the last 4 months. So it's in the chronic category. It's not acute, and it was associated with mild generalized abdominal pain. So there's key, symptoms here, the urgency and tenesmus. So urgency and tenesmus, we call them outflow symptoms. Urgency, that means the patient has the urgency to rush to the washroom. Some of them, they might end up with fecal incontinence because of they have an incident. And tenesmus is the sense of incomplete evacuation after emptying. So this usually reflects a rectal involvement, and we tend to say rectal involvement is more common in UC, the presence of blood as well. All talks with possibility of ulcerative colitis. Again, this is more of colitis presentation. This is more of ileal ulceration presentation. So even Crohn's disease can present with Crohn's colitis. Yet, as we mentioned, because of the rectal involvement as well, and the most common rectal cause of inflammation would be UC rather than Crohn's. So this again doesn't confirm the diagnosis. It just gives you a hint that you think more of ulcerative proctitis or ulcerative colitis here more than Crohn's disease. Now, clinical presentation, as I told you early on, if you're asked about Crohn's disease, you cannot say that is the presentation. I would ask about the extent and the behavior of the disease. So do not forget perianal symptoms. So they have different categories of possible presentations: weight loss, pain, inflammation without infection, impaired growth in pediatric age group, diarrhea, malabsorption. And I just made this slide to make things easier. I tend to say it's easier to remember symptoms in categories rather than just remembering them individually. So I say they have either intestinal or non-intestinal symptoms, and the non-intestinal symptoms are either constitutional or intestinal manifestation. So intestinal symptoms, and you can use both actually for UC or Crohn's. So intestinal, usually diarrhea, the most common in Crohn's disease, followed by abdominal pain, bleeding, rectum, nausea, vomiting, and if you add just perianal symptoms and fistula to genitourinary, with like hematuria, for example, or passing stool per vagina, or whatever, you can add this to Crohn's disease. If you take the yellow box here, you can apply this for UC as well. Non-intestinal is, we say, fever, weight loss, anorexia are constitutional symptoms, and the external side manifestation will come later on, depending on the organ involved. Are the joint, eyes, skin, liver? They are the most common organs involved. Even other organs can be involved, but for sake of making it easy, just remember at least those 4 organs. So we'll come to that later on. Now, this is just, as we mentioned early on, we categorize the disease depending on different, variables. If we use the extent, we talked about it early on. Now we're talking about phenotype depending on behavior. So this is a behavioral classification. In the old one, we called it Vienna. I came up with this. Now we are using Montreal classification, the more recent version of that was revised. So either it's pure inflammatory or structuring or penetrating disease. You can see how is that apparent here. Now this is just to show you perianal fistula. I don't want to expect you to know the detailed subtypes of perianal fistula. You might take this with the colleagues in surgery. But this is a fistula. And a fistula definition is, I just simply mentioned it, is an abnormal, so it's not normal, so abnormal communication between 2 epithelial surfaces. This is how fistula would be defined. So if this is, for example, between the skin and the GI mucosa. If you have a communication between GI mucosa and urothelial mucosa, this is again a fistula. So an abnormal communication between 2 epithelial surfaces is a fistula. Now again, this is just to show you how the presentation differs depending on the location and behavior. But I mean, for sake of exams, remember that the most common presentation is ileocolitis in Crohn's disease, followed by isolated ileitis, 30%, followed by colitis, and then very small percentage of patients will have upper GI isolated Crohn's disease. So it depends on the presentation. If they have intravesical fistula, they might come with recurrent T2I or hematuria, for example, like down here. If they have rectovaginal fistula, they might have. So this 10% of women with rectal involvement will have rectovaginal fistula, unfortunately. So it depends on their, like if they have colonic diseases, we mentioned Crohn's colitis, they will have bloody diarrhea similar to ulcerative colitis. And it is ileocecal disease, they will have vital ileoc fossa pain and maybe sometimes mass even, or diarrhea or fever. This is just showing that again, especially emphasizing on the most common presentation being ileocolonic. And again, this is just as well to show you the differences that we talked about. So there's perianal presence in Crohn's disease. So still talking about Crohn's disease. Rectums tend to be spared in Crohn's disease, yet in some cases it could be involved. We said skip lesions, the endoscopic features, the presence of strictures, the presence of granulomas. So kind of like one picture to show you all of this. This is just to show you, and I believe it's important not to skip this quickly. This is just showing you why really you need to start medications early and identify the disease early before complications arise, especially in Crohn's disease. This is a common, graph to be shown. So on the right side, you can see the black, and the black, ups and downs here are showing the clinical and biochemical inflammatory activity of the disease. So, for example, the patient will have symptoms with high CRP and high inflammatory markers. Then he goes into remission, then another inflammation, then remission, then another inflammation. So we have those peaks, then he is back to his baseline. But yet, on the left side, the red curve here is the thing that we do not see. And I tend to use rheumatoid arthritis as a mimicry. Rheumatoid arthritis, you can see the hand. So if the patient has an erosive arthritis and has an inflammation in one of his small joints of the hands, these are the inflammation. But if you leave them untreated, they will end up with what we call deformity, right? And you maybe learned about the types of deformities in rheumatoid arthritis hands. And so if you intervene later on, even by treating the inflammation, you will not reverse the deformity. And this is why they introduce the disease-modifying agents or something to start early so you can prevent the damage from happening. So the deformity is the analog for the digestive damage or the gut damage. So if you leave the patient without being treated, he will end up with having stricture, fistula, and end up with having surgery. This is why, this is just to show you the importance of identifying the disease early and maybe consider hitting hard with management that we give in certain patients, depending on what we call prognostic factors. Now, for history taking for you guys, I will leave this for you to read. I most likely maybe you're better than me in history taking. I summarize this for you. So if you are taking a long case or whatever, it would be nice to summarize them into this, these categories. Not go over it. I'll leave it for you, and maybe just try to apply it when you see a patient with inflammatory bowel disease. So later on, we can share the slides with you. Anyone can approach me from you as a team leader, and I can share it with you through a link through email. Okay, so a clinical presentation of ulcerative colitis. Again, I tried just to emphasize on certain messages here. Do not miss acute or severe fulminant flare. They might kill a patient. So ulcerative colitis, as we mentioned, it's a colitis. So usually a patient will have diarrhea, usually bloody. But if it is mild, they might have only diarrhea without blood. Abdominal pain could be there. They might have fever. They might have weight loss during a severe attack. They have fatigue. They have urgency, as we mentioned. We call it outflow symptoms or rectal symptoms. And they might have developmental failure. And there is a chance of pulmonary colitis in 1 in 10 patients presenting. Remember this important scoring system called Truelove. This is a British physician from Oxford who his colleagues developed this index to again assess. So you remember we talked about extent categorization. This is assessing ulcerative colitis based on severity. So this is an old one. This is from 1955, and there is a new version, but I prefer to start with the old one. So I tend to categorize them based on the upper two history, the middle two signs or examination, and the last two are labs. So easier for you to remember when I ask you what are the scoring system to use to categorize patient with colitis, you can say Truelove, and it has 6 factors, 6 variables. So 2 history, the number of stool, the presence of blood, temperature and pulse, the signs, the hemoglobin and ASR. Now we introduced CRB together, and we combined the stool with the blood. So this is the new version of the Truelove. We call it modified Truelove. So it's 6 still, but instead of saying blood alone and stool alone, we're saying bloody diarrhea. Now this is back to the extent. Remember, the most common presentation is ulcerative proctitis, so rectal involvement. Again, this is for exam purpose. So if the last 15 centimeters or so, if the colon is affected, which is rectum, we call it proctitis. If it is involving until the splenic flexure, left upper side of the colon, then we call it left-sided colitis or proctitis. Any disease proximal to splenic flexure, even at the mid-transverse, we call it extensive colitis. Okay. So all pancolitis are extensive, but not all extensive are pancolitis. So just one slide for numbers from a textbook. Remember, proctitis, proctitis are the most common presentations of colitis, and ileal or ileocolonic disease is the most common presentation of Crohn's disease. Now, maybe it's difficult to remember all the components of the scoring system. Just would be nice to know the names of the scoring system that we use. We call them clinical scoring systems, so not endoscopic, not histopathological, not radiological. This is clinical. The clinical presentation of the patient. So for UC, we use Truelove, as we mentioned, and we use what's so-called partial Mayo score. So if you are asked, it would be nice, or if you join the clinic, you will hear maybe about those. And for Crohn's disease, we use Crohn's disease activity index or Harvey blood sugar index. I know there are a lot of information for you to remember, but as I told you, I'm trying to emphasize on important numbers that you need to remember. And this is physical examination slide. Again, I can maybe will allow you to go over it quickly later on, just to help you when you start doing your examination stations or you join for physical examination sessions. So it would be nice to remember those signs as physical examination. This is just to show a picture of a fistula. So this is a perianal fistula, the left upper part here. And you can see here the phases of healing. On the right side is the perianal fistula, the left side an abdominal, we'll call it anterocutaneous fistula. So this is before treatment. The patient will have mass discharge and all of that, and after treatment, the patient will have healing. Hopefully, usually there's 30% chance with medical treatment that we give that patient will not need surgery, so he end up with having his fistula healed nicely. Now, diagnosis and differential diagnosis, again, there is no criteria, like with that, like with in rheumatological illnesses, where there are certain autoimmune antibodies that you do, and then you have criteria to meet. So there's no single as well, like a UTI, for example. If you have a urine culture positive, that's it, you have a UTI. So there's no single diagnostic tool in Crohn's disease or colitis. It's a group of tools. You have the clinical suspicion based on the presentation and the symptoms for enough duration. Have biochemical presentation, have radiological and endoscopic, and sometimes surgical. Sometimes we have a difficult patient to diagnose, so we end up with sending them, and this is in very rare occasion, we send them for diagnostic purpose for surgical resection, so we can diagnose the whole thing and then decide about the diagnosis. And this is just in some cases where it is really difficult, for example, to differentiate, for example, a lymphoma or other disease or infectious causes from a pure Crohn's disease, for example. This is more applicable in Crohn's disease, to be honest. And why do we need to do all of the efforts to? We need to do definitely all the efforts to rule out infectious causes or other causes, secondary causes, because this is a lifelong commitment. Talking about chronic diseases, and they will be in lifelong immunosuppression. So we need to do all the efforts to rule out anything that is curable, anything like infection that is self-limiting, medication-induced. Just do all the efforts before you commit a patient to a diagnosis like Crohn's disease, because also colitis, because they are idiopathic, and you keep on giving them medication most of the time, usually lifelong. So, what about differential diagnosis? How do we approach differential diagnosis? So, for Crohn's disease, I tend to say if this is, so it depends again on the extent. So, if this is the most common type, which is ileocecal involvement, then intestinal TB pops in mind, and as well intestinal lymphoma. And infectious enterocolitis is one of the differential diagnoses, and medications. For colitis, for Crohn's colitis, similar to UC, and we'll come to UC in the next slide. Upper GI involvement, remember the most common cause of ulceration in the upper GI is peptic ulcer. So if you have what we call unusual peptic ulcer, a peptic ulcer that doesn't respond to usual standard treatment or extending beyond the usual site, then you start thinking of Crohn's disease of upper GI. Now, what about differential diagnosis of colitis, as we mentioned, whether it is UC or Crohn's colitis? Think of mucosal colitis. Again, it's easily differentiated, but from clinical perspective, both will have diarrhea. Drug-induced, again, can give you a colitis, ischemic, radiation, infections, Behçet vasculitis, diverticulitis, granulomatosis disease like sarcoidosis. Divergent colitis, it's, if anyone knows, or just to explain it quickly, if you have a patient who has, for a reason or another, an ileostomy, so you diverted the flow of the stool away from the colon, then if the colon is staying unused, we call it disused colitis or divergent colitis. So the patient would have colopathy and inflammation and maybe blood because of diverting the stool flow away from the colon. So they will develop inflammation there. Now, this is just some tables from your book for you to review. Now, why do we do history and examination patient IBD or any case? Because it helps us to reach a provisional diagnosis. And if we know the diagnosis, the etiology, for example, if patient known to have Crohn's disease and coming to emergency, it tells us why he's coming with a flare. Is he because took non-steroidal? Is it because of an infection that he had that triggered the flare? And again, to rule out other differential diagnoses and rearrange your list. This is why you need to take history and examination, and then to guide the investigation to the most likely rather than the others, and then to assess severity, whether the patient has mild disease or severe disease. This is why it's important to go for clinical. Now, when we come to investigation, there are different battery of tests that you can do. So we start with biochemical. We call it inflammatory markers. So ESR, CRP, ficaprotectin, albumin, and platelets. Remember, albumin is a negative acute phase reactant that you can use. Radiologically, you can use a plain X-rays. You can use ultrasound bowel and CT angiography or MRI. You can use endoscopy as well to an extent of a capsule in some occasions. And use pathology or sometimes surgery to diagnose versus treat. As well, we rule out other differential diagnoses and complication like infection. So you do CBC to look for leukocytosis. You do stool testing. And we have different stool testing that we can do to rule out infections. And you do acid-fast bacilli to rule out TB. You do quantiferon in the blood. You do BBT testing. You do as well stool testing for viruses or blood tested serological for viruses and parasites. You do renal bone and hepatic as well to rule out extensive manifestation or assess disease severity. It's important as well among the investigation to rule out to assess nutrition, either macro or micro. So you look at anemia by doing a CBC. You look at hematinics, serum iron, ferritin, folate, vitamin B12, and others. Other vitamins and trace minerals. Serological testings are left for difficult to differentiate between UC and Crohn's. It's not endorsed by guidelines lately, so just we'll give you one slide about them for sake of exams. Now, ficaprotectin, remember, as the name dictates, so it's a calcium protein-based marker. It's a fecal test. It's a so protein found in abundance in the cytoplasm of a neutrophil. In the past, we tend to use pus cells or white blood cells in the stool, but it's not stable outside the body temperature. This is why we use this surrogate marker of inflammation. And again, it's not specific for IBD. So any inflammation, even infectious diarrhea, gastroenteritis, or enterocolitis, will give you high fecal protectant because there is an ongoing inflammation. So it's an inflammatory marker that's not specific for IBD. So we use it for two reasons usually. Either to differentiate IBS, irritable bowel syndrome, where there's no inflammation, from IBD in case of chronic diarrhea, or once we establish inflammatory bowel disease diagnosis, then we use it as a predictor or follow-up as a marker to assess disease activity. Now, remember, as I mentioned, serological markers use P, ANCA, and ASCA. These are the most common types. Remember, P, ANCA is more with UC, and remember, it's the P, not the C, ANCA. So the perinuclear, not the cytoplasmic. So P, ANCA with UC, and ASCA, Saccharomyces cerevisiae antibody, more of Crohn's. So if you look about sensitivity and specificity, it has a high specificity. That means it has, so if you have positive P, ANCA, negative ASCA, it has high specificity of UC, and the opposite for Crohn's disease. So positive ASCA, negative P, ANCA, more of Crohn's. You might have in some patients both negative, both positive, so the sensitivity specificity will not be accurate. Now, radiology. What do you think is seen here? Anyone? Or just we have maybe 8 minutes. I prefer usually to share this with you, but for sake of time, I'll go over them quickly. So you can see multiple air fluid levels. It indicates obstruction. So we say obstruction, obstruction, obstruction. But even gastroenteritis or diarrhea because of infectious causes can give you air fluid levels. But if you see them, usually try to rule out obstruction. This is the key message here. Now, this is a variant follow-through showing a classical string sign indicating a stricturing disease, most likely Crohn's or other causes of strictures. And this is a CT showing you what we call it here. You can see the mesenteric congestion with fat stranding. And you can see the wall thickness here, indicated by the yellow arrows here on the left side. And those orange arrows here is showing this congestion of the vasa recta. I mean, congestion of, we call this comb sign, مشط, علامة المشط. And this is a target sign. So again, it's not specific. Those are not specific for Crohn's, but can be seen as Crohn's or any inflammation. So target sign with the thickness and the edema in the wall. And this is a fistula seen on MRI. You can see that between the colon and the urinary bladder. Now, this is what we call it loss of hostration or hostry in the transverse colon. It's seen usually in any cause of colitis, but mainly here in ulcerative colitis is one of the features to be seen. So we call it lead bibe sign. And this is a megacolon, more than 5.5, more than 6 centimeter transverse colon. This is 12 centimeter. So this is megacolon. So toxic megacolon is one of the feared complications of ulcerative colitis or any colitis. So to define toxicity, you need to apply what we call JLANS criteria or LANS criteria for toxicity combined with megacolon. So if there is toxic megacolon, you need to involve the surgeon. This is an indication for surgery. Rarely patients will do better on conservative management alone. So endoscopy, we'll just go quickly over this. This is a normal transverse colon. This is a patient with Crohn's colitis. You can see how different the severe colitis here. Patient with linear, called serpiginous ulcers with cobblestoning. This is mild colitis. This is ulcerative colitis. So you can see how is the diffuse inflammation and ulcerative colitis. And this is just different severities, mild or moderate or severe. So for pathology, remember Crohn's colitis, they have granuloma. Right. Again, this is a granuloma. This is deep fissuring in patients with Crohn's disease and with some mucosal involvement, so more of Crohn's disease. For histology, remember, this is a normal histology. You can see how beautiful the shiny goblet cell appearance, those that contain the mucus. While they have goblet cell depletion here, there is, thickness of the wall. This is cystic. These glands and crypts are nicely and normal and organized. Here there's what we call crypt distortion. The crypts are like branching, abnormal shaped, and there is definitely inflammatory infiltrates, and there are multiple. You can see a lot of neutrophils and lymphocytic infiltrate here. You need to go higher power field to differentiate neutrophils from lymphocytes. So management, we have the last 5 minutes to go over this quickly. Just I tried to put this slide for you regarding basic concepts of management. So induction. So to treat IBD, you have induction phase. You want to push the patient into getting better quickly. So induction phase, they want to maintain that remission. So induce remission, then you keep the patient into remission with what they call it maintenance phase. In the past, we used to use antibiotic for induction in Crohn's disease, mainly perianal Crohn's disease, still being used mainly for Crohn's disease, not for UC, and for induction mainly for perianal disease, in some patients with very mild perianal disease upfront. But it's rarely used as a sole management, to be honest. 5-ASA, remember 5-ASA, 5-aminosalicylic acid, a cousin of aspirin, because they are among the salicylate groups. The other name is mesalazine or mesalamine, British, or 5-ASA, British versus American, regardless, but it is used and it is FDA approved for ulcerative colitis, not for Crohn's. And they are used for mild disease, for induction and maintenance. So I plus M, I got it for here for you just to remember it. So 5-ASA used for induction maintenance, mainly for ulcerative colitis. To some extent, some of the guidelines that tell you for Crohn's colitis, you might use it for mild disease, yet it's not FDA approved for Crohn's disease, to be honest. So steroids, prednisone or budesonide. So prednisone is the conventional steroid that we use. So we use it only for induction, not for maintenance, because of the side effects. And I usually tend to ask you, mention 20 side effects of prednisone. And it's too much, but I mean, just to imagine how bad those medications if you keep them. This is why we shy away from using them. And definitely if the patient uses them for more than 3 months, this is a bad sign. So you use them, they are quick, they are magic, they treat the patient, 60 to 80% response. There are certain patients where there will be steroid refractory, but we don't use them for maintenance, so they are quick, they can be used for induction. Budesonide is a different form of steroid that does undergo what we call 95% first-pass metabolism by the liver, so the systemic side effects is far less than the conventional steroid, yet the efficacy is less as well. And you have two different forms of budesonide. You can read about them later on or ask about them in the clinic. Now, for immune modulators, we use them mainly for maintenance. So when I say immune modulators, I'm talking mainly about azathioprine or Imuran and methotrexate. Methotrexate is only used for Crohn's disease. Azathioprine can be used for both UC and Crohn's. Methotrexate can be used for induction, but azathioprine is mainly for maintenance. So the general rule for immune modulators are slow, so we use them for maintenance, except methotrexate in Crohn's. Now, biologics, you'll be asked about them a lot, so they can be used for induction and maintenance. They are proteins, large proteins. We cannot use them orally. We give them parenterally, either subcutaneous or IV. And we have three, at least, mechanism of action of biologics: the anti-TNF blockers, and we have the anti-integrins, and the interleukin 12-23. And then we have lately the new small molecules that are used for induction and maintenance. Now, remember, as I mentioned for you, it would be nice to remember at least a side effect of any medication, especially for 5-ASA immune modulators. And as I mentioned earlier to you, there are three mechanisms of action for biologics. Anti-TNF, like infliximab, adalimumab, they're used for both Crohn's and UC. There are other two, but we'll just maybe allow you to read or ask about them in the clinic later on. But infliximab, adalimumab are the classic ones that we use for ulcerative colitis and Crohn's. Anti-integrins like vedolizumab, or Entyvio, the brand name, it's alpha-4 beta-7 anti-integrin. It's used both for UC and Crohn's. And interleukin 12-23, the ustekinumab, which is used for both UC and Crohn's, and both used for induction and maintenance. Just try to remember at least the side effects of steroids and other medications. It would be nice to at least remember one side effect. We'll skip on this. This is just regarding the approach that we use. And this is for health maintenance. You can read about this later in IBD, just because I have last 2 minutes here. And this is for extensive manifestation. Again, it depends on you. Just try to remember, we'll give you some concepts rather than going over them overall. So they are not that uncommon, up to 10 to 15%. There are some of them goes with disease activity. You call them concomitant or like parallel to disease activity. And some of them are independent of disease activity. That means they will flare regardless the GI flare. But those will flare usually with the GI flare. So we use them sometimes as a marker to assess disease activity. Remember this for sake of exams, the IBD-associated arthritis, there are 3 types. The peripheral type, the one that is associated or parallel to disease activity is only in type 1, which is the post-oligoarticular, asymmetric, while type 2 peripheral arthritis is independent of bowel symptoms, and as well type 3, which is the axial, we call it ankylosing spondylitis, sacroiliitis, is independent of bowel symptoms. So on the right side, you can see biodermal gangrenosa, we say 50 and 50. So some patients will flare with gut, sometimes will not flare, which will be independent. But erythromanidosum classically is parallel to disease activity. So this on the left side is erythromanidosum. UC or ulcerative colitis associated colon cancer risk. Patient with ulcerative colitis have high risk of developing colon cancer. This is why, and the risk factors, I will leave them for you to read. These are the features that increase the risk in patients with ulcerative colitis to develop mainly remember the extent and the activity and the presence of primary sclerosing cholangitis. So if you have BSC in the liver, the risk of having colon cancer in UC is far higher, and we'll come to what we call it surveillance. This is a classical exam question, which is when to start surveillance a patient with colonoscopy. So a patient has pancreatitis, either UC or Crohn's, you start after 8 years, so you start doing colonoscopy, not for disease activity, mainly to rule out malignancy. If the patient has left-sided colitis, you start after 10 to 12 years. If the patient has proctitis, we say no need, that means average. So for colon cancer in the general population who doesn't have IBD, we start at the age of 45. So we do the same. For patient with BSC, you start now looking for malignancy in the colon, and then you do annual colonoscopy. And this is a classical exam question, guys. And these are the complication, indication for surgery in UC are different, but for Crohn's disease or obstruction, severe anal disease are responsible to medical treatment. They have high relapse rate. This is why after the first surgery of Crohn's disease, we need to put them sometimes on medication to prevent the need for second surgery. And also colitis, the indication for surgery, either in medical failure or complication like perforation of toxic megacolon, or disease who are needing steroid lifelong, or in patient with carcinoma. And why do a patient with IBD flares? These are the causes. Either he's not adhering to his treatment, or just simply his course now is getting a bit worse. And rule out C. diff and CMV. These are important for sake of exams. Infections in patient with IBD, you need to rule out C. diff and CMV because they might mimic the disease flare, and make sure that the patient is not taking a steroidal in case of Crohn's disease. If he starts smoking, this might flare him. And I'll stop here. I know I took 2 minutes, maybe additional from the next lecture. Maybe some of you have exams. So my email is f96263, again, f96263, hospital email at kfshrc.edu.sa. Or you can approach me through my MCD 47803 for urgent questions, or you can even find me in the clinic. I have a clinic usually the Monday morning. Some of you might join me. So please, I apologize again for starting late and not having your questions. If there is any maybe pressing one question, or just allow you to move to the next lecture. So your next lecture is starting at 10:15, right? Anyone?
10:30 inshallah, doctor.
10:30. طيب, can we take maybe one pressing or two so you can have a break for you guys? I know you will need some after this heavy meal. So any pressing one or two questions, guys?
No, doctor, everything's clear. Thank you.
Okay. So we'll leave you guys. Again, you can reach me anytime if you have any pressing questions. All the best. Assalamu alaikum.